Hello, everyone. Thank you for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization, and our mission is to support and educate Canadian families of premature babies. This Premi Chat series is one of many initiatives we have to bring information for NICU families and healthcare professionals. Here, every Friday, we talk with experts, researchers, and parents who share with us their experience and knowledge. And also on our website, canadianpremis.org, parents will find all kinds of resources and support. For example, we just launched a new video series called Welcome to the NICU, to really help parents understand the world of the NICU and what they can do for their babies while they're still in the hospital. And right now, in the face of fears and anxiety brought by the pandemic, we put together the COVID Care Program, offering therapy for families currently in the NICU and for families who've been discharged less than a year. To apply for the COVID Care Program and watch the videos, you can visit our website on the resources page. And today we are going to talk about the preterm brain, focusing on intraventricular hemorrhage, which is known as IVH, which is a very common occurrence in babies born early. The diagnosis of IVH in babies often raises several questions for parents. And in this session, we'll describe what IVH is and why it happens. We'll also address how healthcare providers assess the severity of IVH. And to consider IVH in context, we also describe other brain injuries that occur in babies born preterm. And finally, and most important, what it means and does not mean for the child. And I have the honor to have here with me today Dr. Steven Miller, who is the head of division of neurology at the Center for Brain and Mental Health at the Hospital for Sick Children, professor of pediatrics at the University of Toronto, and senior scientist in the neuroscience and mental health program at the Research Institute of Sick Kids. He holds the Bloorview Children's Hospital Foundation Chair in Pediatric Neuroscience. Dr. Miller and his team focus on improving the clinical care of newborns requiring intensive care, such as those born preterm or with congenital heart disease. Findings from his research program inform new strategies to promote optimal brain development and neurodevelopmental outcomes. Most recently, he co-directs Child Bright, an innovative pan-Canadian network that aims to improve outcomes for children with brain-based developmental disabilities and their families. Dr. Miller, thank you so much for joining us here today. I know you are so busy, and we are very grateful to have you one more time, teaching our families and other healthcare professionals what is happening to the baby's brain.
Thanks so much for having me, Fabiana. It is wonderful to be back here with your community. And I really want to express kudos to you and your team for everything that you do to support the families of babies born prematurely. It is so important for us as healthcare providers to see the support that you're providing for the children and for their families. So I'm going to share my screen so we can jump into this topic of intraventricular hemorrhage in the preterm baby.
Absolutely. We just want to inform our audience that we are going to have a Q&A session at the end. Please feel free to share your comments, your experiences, and your questions. We're going to address Dr. Miller at the end of this presentation.
So I want to be sure as we start that we think about intraventricular hemorrhage not as a single entity, but really as just one contributor to the overall brain health of babies born preterm. I want to apologize on my behalf and those of my colleagues that we love abbreviations. And so let's just start by saying that we will refer to intraventricular hemorrhage throughout this presentation as IVH. And when we think about IVH, I also want to acknowledge that this is a stressful conversation. It is stressful to think about anything wrong in the brain, and IVH in particular. So let me begin by just acknowledging that as we speak about injury to the developing brain, it can't be anything but anxiety provoking. And in all of my back and forth conversations with Fabiana, she is always reminding me that knowledge is power. And my goal over the next 25 minutes or so is to share with you a neurologist's approach in terms of how we think about IVH. And in doing so, I hope to be able to help you in your conversations with your healthcare providers and with each other so that we can all start to begin using the same language. I have no financial disclosures to disclose related to this topic. Some of the work that I'm going to be showing is from around the world. Others is from our team currently in Toronto, and also with our colleagues in Vancouver at BC Children's Hospital and the University of British Columbia. And in both of these cities, we have been so privileged to work with families of babies who have been born preterm, who have participated in these studies for many years. And it is really through their contributions that we've been able to advance not only our understanding of IVH, but also how we can better care for babies with IVH. Now, I expect most people saw a neurologist and expected to be hearing from someone directly about the brain. And we are going to turn to the brain very quickly, but I wanted to start with this diagram because I think it illustrates what we really care most about. And that is the child, their experience of joy, their behaviors, their interacting with friends, their academics, whether that's drawing, building, math, or reading, and so as we delve much deeper into the brain of the preterm baby, I will keep this picture with you as we discuss how the brain relates to these outcomes that matter most to us. So we're going to focus on a neurologist perspective of intraventricular hemorrhage. We're going to ask, what does IVH mean? And very importantly, we're going to look at what doesn't IVH mean. And if there's one thing that you take away from our conversation today, is that the brain in the baby and through childhood is not static. It's not okay. I'm backstage again. Sorry about that. And I wonder.
It's okay, Dr. Miller, we can see you and you can see your slides. If you can go back to your presentation, I think you're on slide number 4, as I can see from the screen.
Yeah, and what I'm going to try to do is show this slightly differently. If you excuse.
That is totally fine. In our new world with technology, this is happening and everybody understands that.
That's right. So we're all doing our best here. I appreciate that.
Absolutely.
Show my screen this way so that I can keep track of what we're doing.
That's perfect. We can see you and we can hear you and see your slides.
Perfect. So excuse the banners at the top, but let's come back to this issue of IVH from a neurologist perspective and look at this issue of the developing brain. So these are MRI images that are from a baby who was born 3 months early or at 28 weeks gestation, scanned with MRI at 2 weeks of age, And then again, just before her due date, 9 weeks later, at almost 40 weeks gestation, full term. You can see on this MRI image that we've got this dark ribbon. This is the cerebral cortex, this beautiful ribbon on the surface of the brain. Here's the front of the brain, the back of the brain, the left side and the right side. And you can see that this ribbon, which contains billions of neurons, as these neurons or nerve cells will make trillions of connections to make room, there's now folding of sulci and gyri. And so by term age, we now have a brain that has an adult morphology. It looks like our brains, it's just smaller, but it's still less mature. And what is happening here is this incredible period of brain development. When we met with your team last time, we spoke about how everyday issues in the ICU, such as pain, might influence this period of development. And I want you to keep this development in mind as we think about intraventricular hemorrhage in the brain, or IVH, because IVH is occurring in this period of rapid development. And so as we look to how IVH influences outcome, we need to remember that we have lots of opportunity for the brain to grow and develop over time. So now let's take an even deeper look at what's happening in the brain. And to understand IVH, we also need to understand what the ventricles are. So the ventricles are normal fluid-filled spaces in the brain, showed here in red and in pink or purple. All of our brains have cerebrospinal fluid, fluid that fills the ventricles and then comes out and bathes the brain so that when we shake our heads, there's no bumping of the brain against the skull. And so these are normal fluid-filled spaces of the brain. And in the baby brain, there is a tissue that is present between the ventricles and the normal brain tissue called the germinal matrix. In the first and second trimesters, the germinal matrix shown here in pink schematically is where we generate our nerve cells, neurons, and our glial cells, the support cells. So this is the factory for cells. Because we need this area to be producing all of these cells, it's not surprising that it gets lots of blood supply. So we've got lots of blood coming into this area because this is the factory for most of our brain cells. These cells are born in the germinal matrix and then they migrate out to take up residence in the cortex or in the brain's relay stations. And by 25 weeks gestation, the germinal matrix has done its job. And so it stops generating all of these new neurons. It might generate some more glial cells, but it really starts to involute over time and go away. It turns out that the blood vessels in this part of the brain, the germinal matrix, the little blood vessels called capillaries, their cells are the most metabolically active cells in your body at any point in your development, anywhere. So it's not surprising that this germinal matrix is an area of the brain that's at high risk for having bleeding. And the medical term for bleeding is hemorrhage. By term age, the germinal matrix has gone away. So if we now look at IVH, which starts in the germinal matrix, it's not surprising that IVH then is common. We have this developmentally regulated part of the brain that is highly metabolically active, has fragile blood vessels, and requires lots of energy. So fluctuations in how blood is flowing and energy is being delivered will result in little hemorrhages. And so IVH occurs in almost 40% of babies that are born preterm, particularly babies that are born very preterm. Now, I mentioned that the IVH goes down, the germinal matrix goes down over time. So not surprisingly, the occurrence of IVH decreases dramatically over time. So if we look at germinal matrix hemorrhage, it occurs, we find it on ultrasound in over half of babies born at 25 weeks, under 25 weeks gestation, 40% at 25 to 26 weeks, and onwards down. The bleeding that leads to IVH begins in the germinal matrix and then spreads into the ventricles, the normal fluid-filled spaces of the brain. So IVH is also much more common in the extreme preterm babies, becoming less and less common as the germinal matrix disappears towards term age. And so really, this is a condition of the very preterm baby. I mentioned that this is a highly metabolically active part of the brain with very vulnerable cells. And so the main risks for IVH in the baby born early are breathing problems leading to fluctuations in blood flow to this germinal matrix, and illness, infections, low blood pressure, things that will result in not enough energy being distributed to the germinal matrix. Now, IVH is a condition that largely happens in the younger preterm baby and is most common early in life. So 50% of germinal matrix hemorrhage happens on day 1, 25% on day 2, 15% on day 3. About a third of germinal matrix hemorrhages, the precursor to IVH, will then progress over the next 3 to 5 days. So germinal matrix hemorrhage is where it starts, and as it extends, it breaks through the germinal matrix into the normal fluid-filled cavities of the brain called the ventricles, and that's why we have IVH. We think this relates to fragile and immature vessels that are vulnerable to fluctuations in blood flow to the brain. This was reviewed very nicely by my colleague Diane Wilson, the nurse practitioner who glues together our neonatal neurocritical care program at SickKids with her colleagues in the neurosurgical program. And I've provided a link here where this PDF is located if people are interested in reading more about this. So how does IVH present in the baby born preterm? And to go forward for simplicity, let's consider germinal matrix hemorrhage and IVH together. I'm just going to call this IVH. Now, it's important to recognize that most babies who have IVH don't tell us that something's happened to the brain. IVH is most often a silent condition. When it presents with symptoms, the baby might show us either subtle or more overt signs, things like pauses in breathing, slowing of heart rate, a weaker suck, lower tone, or bulging of the soft spots of the brain because the cerebrospinal fluid that bathes the brain between the skulls starts to extend outwards. And this is why we have protocols in our neonatal intensive care units that include routine ultrasounds, because we want to look for IVH, recognizing that this is a condition that often occurs in the first 3 days of life. Nowadays, when I go up to the NICU to speak to families about IVH, everybody wants to know how it's graded, and people want to know the severity of IVH. So to orient us now to these sagittal ultrasound images, so here we have the front of the brain, the back of the brain, the eyes would be under here. Same thing on this ultrasound, the front, the back. In red are the lateral ventricles, and dark here are the lateral ventricles. So I hope you can see the correspondence between the ultrasound and the cartoon. We're taking one slice across the brain through the midline, just off the midline, from the front to the back. This dark area are the normal ventricles, and this is what we expect to see. Now remember, in the cartoon, I showed you that little pink area of germinal matrix. And so shown here by the arrow is this bright little spot. This is the germinal matrix hemorrhage. The bright spot is the bleeding. And so this is what we see with grade 1 IVH. That is germinal matrix hemorrhage that allows for a little bit of blood into the ventricles. We move to grade 2 IVH, where we see here's the ventricles that are dark, the front here, the back here, and it should be all dark back here, but instead we've got this brightness. This is bleeding within the ventricles. 10 to 50% of the ventricles being filled with some blood. Grade 3 IVH means that more than half of the ventricles are filled with blood, and we start to see some expansion of the ventricles. And so notice here how instead of seeing all this dark area, we see a little dark, but it's mostly filled with the brightness that is the bleeding. So we go from grade 1, just in the germinal matrix, all the way to grade 3, more than half of the ventricles filled with blood. So that's the numeric grading of IVH. As neurologists, though, we pay even more attention to what happens much less commonly, which would be the complications of IVH. And to keep with complex abbreviations, I'm going to show you 2 of them. The first is something that is termed Periventricular Hemorrhagic Infarction, or PVHI. We used to call this grade 4 IVH because we used to think that this was blood breaking through the walls of the ventricles, extending into the brain tissue. We now know that that is most often not the case. What's happening with PVHI is we have a larger bleed, most commonly a grade 3 IVH, filling the ventricles and compressing the veins of the brain. Now we have arteries that bring oxygenated blood to the brain and veins that take that oxygenated blood away. If we compress the brain, compress the veins, the blood is flowing into the brain and has trouble getting back out. So we get a hemorrhage or a bleeding. So peri means close to the ventricles. So we have something close to the ventricles. It's bleeding, so we call it hemorrhagic. And infarction means injury to the brain or a stroke. So neurologists think about this as a venous stroke or as a periventricular hemorrhagic infarction. So this is a complication of IVH and is increasingly uncommon. The other abbreviation, PHVD, refers to post-hemorrhagic ventricular dilatation. That is, after bleeding, ventricles enlarge. This too is a complication of more severe IVH. And so it doesn't occur at the time of the grade 3 bleed, which is filling the ventricles and expanding them. This is something that tends to occur over time, a little bit more insidiously, where we continue to see the ventricles dilate. So that's the landscape of IVH. What does it mean for the child? Well, importantly, mild IVH, which all group together, grade 1 and grade 2 IVH, the neurodevelopmental outcomes of these babies are totally comparable to those babies who don't have IVH. There's some controversy whether the risks are slightly increased, and for that I'd have to say we have to consider other brain injuries, in particular white matter injury. One of the issues we talked about when we met last. And so I'm going to come to more severe aspects of white matter injury shortly. But for now, suffice it to say that when we looked at the relationship between IVH and white matter injury in Vancouver and in Utrecht with our Dutch colleagues, we see that regardless of which center you're at, with IVH, babies have more white matter injury. So I'm focused on IVH because that's what Fabiana asked me to do. But this is only one component of brain health in the preterm baby. What about more severe IVH? So grade 3, and this issue of periventricular hemorrhagic infarction. It's with these lesions that we see the occurrence of motor and cognitive difficulties for the child start to increase. And the occurrence of motor difficulties is very tightly related to the severity of these changes and to where they are in the brain. So let's look at this in a little bit more detail because there's often a tendency to equate periventricular hemorrhagic infarction, or PVHI, with cerebral palsy. And that is not always the case. So if we look at unilateral PVHI, that is brain injury that's occurring on only one side of the brain. Cerebral palsy is described in about 2/3 of babies with this change, but it's either not present or mild in the vast majority of these babies, with only fewer babies having more moderate or severe concerns. These issues are much more common when the brain injury occurs on both sides of the brain. So the diagnosis of PVHI does not mean cerebral palsy. It does mean the need to consider the risk of motor concerns and cognitive concerns, as we can see reflected on the Mental Development Index of the Bayley scales, a standardized developmental test with a mean of 100 and standard deviation of 15. And you could still see babies with a unilateral PVHI who are testing in the normal range on this Bayley scale. But we do need to consider the severity of the injury and whether it's on one side or both sides of the brain. And this really highlights the need for our communities to do all we can to prevent IVH. And we've seen the introduction of brain care bundles across Canadian NICUs. Remember, IVH tends to happen in the first 3 days. And so the brain care bundles to prevent IVH are really focused on these first days. And these are things like keeping the head midline, elevating the bed, minimizing pain in procedures. So there's some connection between our last conversation and this one. So more gentle care, avoiding fluctuations in blood pressure, and aiming for optimal, more gentle ventilation to try to prevent IVH. And again, this is from Diane Wilson and reflects her conversations with colleagues across Canada. The other big change that we've seen that is particularly exciting to me is how we're starting to think about PostHemorrhagic ventricular dilatation, or PHVD, that expansion of the ventricles that happens sometimes after a severe IVH. And because dilatation of the ventricles, when it is severe and requires treatment, requires a shunt with our colleagues from neurosurgery, so a procedure to help drain off the extra fluid, we've tended to treat this dilatation with a shunt only when absolutely necessary. Our colleagues in Holland have taken a much more proactive approach. I shouldn't say more proactive, have taken a different approach to the treatment of PHVD, where they intervene very, very early on when they see ventricles growing too big. When they cross a certain threshold on ultrasound, they do repeated lumbar punctures, followed by a reservoir that allows the team to remove fluid from the brain. And you could see here in this baby, repeated lumbar punctures. Ventricles are too big here. And then the ventricles then normalized with this procedure. And the child's developmental testing was well into the normal range. And so when they look at the outcomes of babies with PHVD who have been treated this way, their outcomes are largely totally in the normal range, where these scores in the typically developing population have a mean of 100. And so we've been working very closely with the Dutch teams. Again, this is a credit to Diane Wilson and her colleagues in neurosurgery to see how can we most proactively address this issue. So not only do we have a rapidly developing brain that gives us lots of room for more brain development, the healthcare teams are really looking very critically at how can we help prevent the complications of IVH to help promote neurodevelopmental outcomes. When we think about routine imaging of the baby born preterm, there's just a position statement by the Canadian Pediatric Society, led by principal author was Mireille Guillot, now a neonatal neurology fellow with us at Sick Kids, who will be joining the faculty at University of Laval in Quebec shortly. Van Chow, a neonatal neurologist in the Sick Kids team, and Brigitte Lemire, a neonatologist at CHIO. And this is why these protocols involve screening head ultrasounds, initially in the first week of life, again, because IVH tends to happen early, with plans for repeated ultrasounds to be sure that we're looking for the more severe evolution of IVH or complications of IVH. And we consider MRI when we need a closer picture of these complications. The other brain change that happens in the preterm baby that we diagnose with ultrasound and can often be confused with PVHI, so I want to bring it up here, is this issue of periventricular leukomalacia, or PVL. This occurs with cysts in the white matter. So now apologies, but we're looking front on in the brain. So the top of the brain is here, the bottom is here, the left side or the right side, the left side. And here we have the ventricles, the normal fluid-filled spaces of the brain. And here in this baby, we see cysts in the brain. So another kind of injury to the brain that is often predictive of a child having spastic diplegic cerebral palsy because the leg fibers are passing right down through where these injuries are. Fortunately, PVL, now shown on this front to back image, ultrasound is these cysts over here, has declined dramatically. In work that I was privileged to do with Shannon Hamrick, an neonatologist at UCSF and now at Emory, we saw in our San Francisco NICU how the incidence of PVL declined tenfold from 2% to 0.2% in babies 24 to 32 weeks gestation. So just this incredible decline in a significant brain injury. And the main predictor of this was more general use of mechanical ventilation, an issue that has now been widespread since this time. And so it's been very interesting to see how optimizing newborn intensive care can be so protective to the baby brain. Linda DeVries and her colleagues in Utrecht have similarly shown a dramatic decline in the incidence of PVL, and even more importantly, showed that that was coupled with a lower incidence of cerebral palsy. So important that while we wait for new brain protection strategies, that we continue to push the research to understand how our cares in the intensive care unit can be used to promote better outcomes. White matter injury is not always as severe as PVL. Here's an example that I showed the last time we were together as these small little punctate areas of white matter injury. Sometimes it's a single spot, sometimes as in this baby, it's more of these bright little spots. And so again, to highlight how when we think about IVH, we need to think about this in the occurrence of everything else that's happening in the brain when we want to think about what the influence is on the baby. Let me bring you back to the images we started with. Here's that baby that we saw at 2 weeks of age, again, just before her due date, and now 8 years later. And notice how the brain has changed again, just so dramatically, an incredible period of brain development over this time. And so I really want to emphasize this issue of not thinking about the brain as static or the occurrence of IVH as something that is fixed. Fixed as in not moving. This is something that we need to think about. What are the opportunities we have to promote development in babies with IVH and in any baby born preterm? And so the last piece of data that I want to show you is this relationship between socioeconomic status and neurodevelopmental outcome in preterm babies as it relates to the severity of brain injury. And using MRI in research studies, and again, shout out and thanks to all of the families that participate in these studies, we've been able to quantify a severity of brain injury so that we could start to understand how brain injury predicts outcome. And when we look at group differences, we see that babies with brain injury have lower scores on their developmental tests than babies without brain injury, even if there's wide variability amongst both groups. When we start to look, though, at post-NICU, after the NICU modifiers of this outcome, I want to draw attention to this group in orange. And this is the group that was defined as the higher socioeconomic status group. We could look at mom's education as we did in this graph. We could look at dad's education, total household income, access to services. It all gives us curves that look this way. So this isn't about the mom, this is about the social environment. And we could see that in this highest SES group, brain injury is not predicting lower outcomes. So as a neurologist, I have to say that most of my research team's focus has now shifted away from the NICU to try to understand what is happening here. What are the things that we could be promoting through our follow-up clinics to help mitigate the influence of early brain injuries such as IVH, whether that's reading, listening to music, other aspects of parenting, nutrition. We don't yet have the answers, but I did want to share our excitement for that we have in terms of looking for modifiers of outcome of early changes in the brain in the long term. So I hope to have shared a neurologist perspective of IVH, to have given you all a shared vocabulary for how we think about IVH, how we talk about IVH, and to highlight that IVH remains very common. We're making exciting strides to preventing the complications of IVH. And even more importantly, we need to think about IVH in the long term for the child. I want to thank the neonatal neurosciences team, a picture now out of date pre-COVID. Boy, do I miss getting together with this group. I'm very grateful to them for their ongoing work despite the pandemic, often from home. I want to thank our colleagues in Canada and around the world, our sources of funding, and most importantly, again, to the families that contribute to these studies and often very stressful periods of their time. So Fabiana, at this point, I'm sorry for the technical disruptions, but I'd love to take some questions.
Thank you, Dr. Miller. That was incredible. It's really a crash course in the brain, about the brain. And I'm always so grateful to you to share with our families in a language that we all understand. So we have people joining us from UK, from Libya, from all over Canada. Thank you, all of you, from watching us and for sending your comments and questions to Dr. Miller. Dr. Miller, there is one here in Spanish. I will try my best to translate. Sorry, Jose, my Spanish is not that great, but I believe you're asking about the delay in the cord clamping, if that helps with IVH. I hope I'm correct on the translation here. Dr. Miller, it's becoming a common practice in Canada, right, to delay the clamping? Dr. Miller, can you hear me?
And so the issue of delayed cord clamping is an important one. There's increasing evidence that delaying the clamping of the umbilical cord can help with the transitional circulation and can help those fluctuations of blood flow in the aim of preventing IVH. The evidence we have shows some protection to IVH. More studies are needed. And it's been very interesting to see how interest in cord clamping now, delayed cord clamping, has extended to other populations, including babies, for example, who are full term, but have heart disease or congenital heart disease. So you're picking up on a really important area of research and another great example of how we can use the strategies that are available to us to try to prevent brain injury. And this is what makes having a window on the developing brain with things like ultrasound and MRI so critically important.
Okay, we have another, so I'm trying to monitor our chat while you're answering the questions. We have another question here from Lori Romas. What about grade 4 on right, grade 1 left, so both sides, but mild on one side? Does that still count as both sides? What are the punctate lesions?
Okay, Lori, this is an important question, and I always appreciate questions that give me a chance to clarify some of what was presented. So when I showed those data of unilateral versus bilateral periventricular hemorrhagic infarction, the bilateral referred to the periventricular hemorrhagic infarction on both sides of the brain. And we really try to stay away from grade 4 as a descriptor because it's not just a grade. When we think about PVHI and what follows, it also matters where in the brain the injury is. So an injury that's involving the motor pathways centrally in the brain will have a different outcome than an injury, for example, that's limited to the very front part of the brain, where we might not see any difference in motor skills. So I want to use your question, an important question, to emphasize that we need to think beyond the grading to what parts of the brain are influenced. The question about punctate white matter injury, maybe Fabiana will have me back with this group to spend some more time about white matter injury, which is another type of brain injury that preterm babies acquire. Similar incidence to IVH, about a third of babies will acquire these little changes in the white matter. Through work, people like Jesse Guo, an MR physicist at Sick Kids, and others around the world, we now recognize that it's not just the amount of these lesions that matters, it also matters where in the brain they are. So we've been hard at work with our colleagues, translating these advanced imaging studies to clinically actionable rules, not just to identify the babies who are at higher risk and might need supports for their development, but we also recognize the important need to reassure families. When we think outcomes will be fine. And so we're also looking at these predictive tools as an opportunity to identify our chances to be as reassuring as possible for families.
Absolutely. We have one more question. Oh, that's very informative from Pakistan. We also have a question or a comment, yes, from Inayat from Pakistan. Any effect of neuroprotective medicine in outcomes of babies with IVH?
So thanks for the question. So in terms of neuroprotective medicine, if we think about pharmacologic agents, things that we inject, I'm not aware yet of a good pharmacologic therapy. We had a lot of hopes for erythropoietin that haven't sort of panned out for the preterm baby. We're waiting for more data on the term baby. There's a lot of strategies, including stem cells, that are in the works in labs around the world. So I think this is a topic that I hope we come back to in time, because I'm sure that the answer will be different. We've been much more focused on these everyday issues that we might be able to influence. So how can we deliver ventilation in a way that prevents IVH? People like Khurshid Mohammed in Calgary, a real champion for brain bundles and brain protection that way. Can we use more gentle ventilation? Can we use appropriate ventilation? It's not about gentle or not gentle. It's about the right ventilation for the right baby at the right time to see that decline in PVL. Dramatic. No medicine to do that. And then importantly, can we try to minimize pain? Let me come back to that important issue to try to prevent these fluctuations in blood flow to try to minimize IVH. So it's been really fantastic to be in this field over the last years and see the dramatic changes. So I hope that my answer to this is just taken as a single point in time. And I'm sure within the next months or years, there's going to be a very different answer to that question.
Absolutely. Dr. Miller, so many comments here. We have here from Leslie, so great for our neurosurgery team at Sick Kids. Leslie is a preemie mom. Her son is almost 13 years old now. Also have this question from Daniela Taylor. Are there studies, data that showcase what particular parts of the infant care help minimize the long-term developmental of the child?
Oh, Daniela, that is a great question that I wish I had a better answer to. And this is something that we and many others around the world are now focused on, particularly beyond the ICU. And I want to shout out to Dr. Ann Sinnis in Vancouver, who leads the Canadian Neonatal Follow-Up Network. I'm sure she's well known to your group. I don't know if she's online. But she always, for years, has been asking me, why do we have to think about brain protection opportunities as stopping at NICU discharge? We really need to think about opportunities to promote the brain's development across the life course. And that's why I showed you that image of the baby's brain as you move towards 8 years of age. You know, in childhood, it's undergoing this other dramatic change over time. And so how do we support that to be as optimal as possible? Ruth Grunau and her colleagues in Vancouver have done very important work looking at parenting, the influence of parenting and more optimal parenting to mitigate the influence of early pain. Data, again, I showed last time. Trish Williams at Sick Kids, a neuropsychologist, very interested in how to support parents as a way of promoting infant and child mental health and development. And so I'd refer you to About Kids Health and her I Interact North program as another opportunity. There are colleagues in pediatrics and nutrition sciences at U of T and elsewhere looking at how we could provide nutrition that supports this development. And so if we have any trainees on the line now, you are coming into our field at such an important time to start asking these questions and seeing how we could give Daniela an even better answer at the next.
Absolutely. So here from Leslie, is there routine training for clinicians to help them convey this information without implying worst case to families? Dr. Mila, this is the conversation we often have among ourselves, and how can we talk to families without taking their hope away. And sometimes I think there is a way that we have to reevaluate our own values on having a child with disability or with special needs. But how do we do that with families? I think specifically in the NICU, and that information is first come to us, because it is the hardest conversation you have to have with the families, and the one that we always going to remember.
So, Leslie, I can start by saying how impressed I am at how I've seen my own thinking and practice around this change over time. And this is an area that I identify for myself as needing continuous improvement, because I'm not sure that any of us could do this as well as we all strive to. I think we recognize how stressful this is for families in the NICU, and trying to find this balance, as Fabiana pointed out, in terms of being realistic, conveying the information that we have. But to your point, and something Fabiana reminds me about all the time, is without taking away hope. And I hope that the families in the NICU that I interact with, or that my colleagues interact with, see this as a partnership. And there's often some pressure to get the prediction right early on. And yet what we need is a relationship over time. And this has now become a real area of focus for us in our neonatal neurology training program. It's a major issue of conversation around the child neurology community, and I know the neonatology community. I've been privileged to work with Eric Racine, Mike Chabelle, and their colleagues at McGill on trying to have a framework for how we can better communicate these really important issues. And so I can only answer your our training program.
Sorry, Dr. Miller, we lost you for the last 30 seconds.
Okay, but I hope that we continue to strive to do better, and it's something that I think my community is invested in.
Absolutely, Dr. Miller, and nobody better than you to actually teach that subject to clinicians, because I feel you or my son's neurologist. We were very fortunate right in the beginning of our journey when my son was first diagnosed with quadriplegia cerebral palsy. And after you, I heard many "I'm sorry," and you were the only one who never said sorry for my son's condition, and you always encouraged me to do whatever was best for my family, and I will never forget that. And you know, when I posted I was going to have this chat with you today, I had a lot of messages. Oh my God, we love Dr. Miller. So you're very well loved in our community of parents with special needs and kids with cerebral palsy, because you do know how to talk to families. And I wish every family could have you as your neurologist, especially in the beginning of this journey. It is a long journey. And I feel that first conversation really sets the tone for our journey ahead. Because when you hear sorry for your child to have a PVL or to have anything at all, and it comes with a sorry, I think it sets you to go in the wrong direction. But when you learn how to, okay, this is what your child's gonna look like. Your child might surprise you with what your child can achieve, or if your child, you don't know what the future holds for that family. As you mentioned, what the influence on the family later on in life is so important. So you don't really know. But when you come with your heart that it is okay, and we are going to walk this journey together as a clinician, as a family, you are setting that family for success, no matter what is the outcome or the development of that condition. So that is my feeling, having a son who had PVL, who is now 8 years old and has dystonia, he has quad CP. It's not an easy journey, but with the right support, we can all thrive as families, and having the right clinicians on our side, it's so key. And I do hope you continue to work on that with so many residents and fellows across Canada, so they can all have that better experience and that initial journey a little easier, because it is hard. So there's so many questions here. I don't even know where to go now, because I think I lost track of our questions, and we just have a few minutes left. Has there been a follow-up of how many kids have IP in school age kids? Tina,
I'm sure that there has been, regrettably, I don't have the answer to that offhand. There's been a real increase in the interest of longer term follow-up and understanding what's happening at school. That's both in Canada, focused on school age and teens, and also an international community who is working, Fabiana, to your point, in partnership with adults who are born preterm to understand what's happening in the longer term. Saroj Segal's work at McMaster has been particularly informative. And so we've really been trying to push our funding partners to recognize the importance of longer term follow-up. And in doing that, if I make reference to ChildBright, the National Patient-Oriented Research Network, it's working with families to identify the outcomes that matter most to them. And I really appreciate you bringing up the question of IEP, an individualized education plan, and not asking about IQ, because what we're hearing from families is not, can you give us a measure of intelligence? It's, can you help my child thrive at school? And that goes beyond academics. If we come back to the cartoon I started with, it also has to do with the experience of friends, joy, and happiness. So it's great to see a more holistic view of outcomes emerge. And Canadians, not me, my Canadian colleagues have really been leaders in that field internationally.
So Dr. Miller, you already have an invitation from our audience to talk about white matter, PVL. So I think you have to come back to our Facebook Live. And I will also want to share the website that you have a lot of information. Can you talk a little bit about this website, Dr. Miller, and what families can find there? I think, can you hear us? Yes. Okay.
So, and I'm happy to provide any other websites to post for you from the material that I have.
Okay, I ask you if anything that the families, what can families find in this website, Dr. Miller?
This is, we've just started having findings from our research studies that we could post. And so this is still a work in progress. I hope people find it interesting. I'll ask you to share your feedback with Fabiana if there are things that we could do to make it more accessible or more relevant. And I'd bring you back to the ChildBright website. Fabiana started with the importance of COVID and the extra stress, and I'm impressed at the resources that our central office team has put together, particularly related to COVID. And so please have a look at childbright.ca, and it should be easy to navigate.
Thank you, Dr. Miller. We also have a comment from Geoff Miller. He's from UK. He's a 42-year-old preemie. So he's always following and very engaged in this community as an adult, which is always very wonderful to see an adult giving their perspective and what happens in life after the NICU. But Dr. Miller, thank you so much for joining us here today. I'm looking forward to our next conversation. I'm always so grateful to have you sharing your knowledge and your expertise with our family. So thank you.
Thanks so much for having me. It's great to be here.
Thank you. And thank you everyone for watching us here today. The video for today's sessions and all the videos from our live series are available on the CPBF website, which is canadianpreemies.org. right here. And we are a charitable organization, and we believe that through education and support, we can empower families, ensuring they are ready to care for their premature baby. Visit our website, consider making a donation. Together, we can create a brighter future for all premature babies and their families. I will see you again next Friday, 1 p.m. Eastern Time. And stay well and have a good weekend, everyone. Bye for now.